Welcome, everyone, to the third Wood Services and Social Innovation Symposium. This symposium is focused on integrated and complex care for special populations. I'm Nikolai, and I'm the Education Platform and Social Media Manager at the Social Innovations Journal. We are proud to partner with Wood Services on this symposium, as well as their new book, Thriving Through Transformation, which we will discuss momentarily. I will start by giving a brief welcome so we can get right to this amazing panel of speakers. Today's session is moderated by Tine Hansen-Turton, the CEO of Wood Services. The series of symposiums is by the Wood System of Care book, Thriving Through Transformation. If you haven't already given this phenomenal book a read, we encourage you to do so. This book is available for free as a PDF or as a physical edition, which can be purchased. The QR code on the screen will take you to the Amazon page, but if you can't scan in time, do not worry, as I will post in the chat box once I've concluded. So this is the third of 4 symposiums. The final one will conclude on April 12th, titled Strategies for Avoiding the Cliff at 21, Models for Education, Behavioral, and Family Supports. To give some context about the journal was founded in 2009 and has been publishing for just under 14 years. The mission of the journal is to serve as a bridge between the world of practitioners and academics. We publish 6 editions annually. Themes range from education to social mobility. We usually partner with a global content leader on their particular issue. Through that process, we curate these editions. We are excited to announce our next edition will be launching next week in partnership with the Tamrick Institute. As we do for all our editions, we invite you to join us for the Meet the Authors event. This event is free for all and is a great way to communicate with authors of this fantastic edition. So keep an eye out in the Zoom chat for the link to register. Last, we always are interested in articles for the journal, as we view ourselves as an open access journal that is peer reviewed and indexed. We are always looking for new themes, so we invite you to write. With that, I'd like to turn it back to Tine, CEO of Wood Services. Tine, the floor is yours.
Thank you, Nikolai, and thank you everyone for joining us. And I see more folks that keep joining, which is always great. So yes, I'm President and CEO of Wood Services, and really happy to welcome you to a third symposium. This one is an exciting topic for those of us who is with you today, but I think also a great interest to many folks around the country, the idea of integrated and complex care for special populations. And again, it's the third in a fourth symposium series held from January through April. Now, the inspiration for the series is a book that Nikolai talked about. We put together here at Wood Services, Thriving Through Transformation, a practical guide to creating organizational change in the social sector. And it really was one of those things, and you spend 6 years together with your team. And we thought that we spent a lot of time changing ourselves and transforming our agency. And there was just so many lessons we wanted to share. And before we knew it, we had put a book together. And we also like that because it's a way to teach our staff and our colleagues, et cetera. And we thought we would share it with everybody else because there's some good lessons and hopefully for everybody else. The Thriving Through Transformation book is available on Amazon. But more importantly, we will send you a PDF version. This is not about making money, but telling a story and also hopefully helping you all think through your own transformational changes you want to do in the organization. And we'll also send you a PDF version. You can also get it in the website of the Social Innovation Journal, as well as also the Wood website. Now, just a little bit about Wood Services. We're a system of care for individuals with intellectual disability, autism, behavioral health, and mental health challenges. But the themes in the book is really applicable to any organization in the health and human services sector specifically. For these first 2 symposia series we did, we focused primarily on vision, strategy, and culture, and what it takes to operate in a more challenging and changing health and human services environment. We also focused on employee engagement, where we highlighted policy changes and strategies that both national and regional organizations have to do to really focus on addressing the dire workforce crisis, specifically in our more direct care sector. But today we're going to sort of pivot into, I would say, more the populations that we serve, and we'll talk about complex populations and how we all collectively need to solve that problem and support them, and how we address sadly fragmented systems and gaps in care and often outdated funding mechanisms in the supports for serving more complex populations, and especially those who require lifelong care, which is the case in our sector. I'd now like to ask each of our panelists to just briefly introduce themselves and their affiliations. And let me start with Stacy.
Good afternoon, everyone. Stacy DiStefano. I'm the CEO and founder of Consulting for Human Services.
And Sila?
Hi, I'm Dr. Sailaja Musirari. I'm the Chief of Psychiatry and EVP of Integrative Medicine at Wood Services.
And Melissa?
Hello, everyone. I'm Melissa Fox. I'm the Chief Operating Officer at Ascendant Integrated Health.
And Chris?
Hi, everyone. I'm Chris Wolf, the Executive Vice President, Boundless, organization based out of Ohio.
So let me just briefly state the why we transformed Wood Services and sort of some of the stages of the books, and then I will get into asking some of our panelists to go more deep dive into the populations that they serve. I came to Woods about 6 years ago, and I thought I understood vulnerable and complex populations. In fact, Melissa and I worked together for years in serving underserved communities, urban, rural, you name it. So I thought I knew it all. Like I think Melissa and I, we thought we knew it all, right? But the reality is that, even though I'd worked in public housing and healthcare, worked on social services, substance abuse treatment programs, early intervention, sports coordination, and also serving as a COO of a complex organization, again, serving vulnerable populations. All of this, I thought would have prepared me to walk into an agency serving the intellectual disability community, but little did I know. And that's really the story, I think, from my perspective and the focus today. I've never seen a population, I would say, as vulnerable and medically and behavioral complex as the people we serve within the Woods system of care. And as effectively as Woods provided services at the time, we also knew we had to prepare for a rapidly changing market and also an environment. And really focus in on our strength, which was how do you wrap services around complex populations, both in the ways we do now, but also in community-based settings. So from my perspective, it was a very exciting opportunity to sort of take a healthcare background, work with colleagues to reimagine and sort of reposition Woods for future growth and development. So that's exactly what we set out to do. And what we realized is that as part of this process, we needed to become a lot more agile, so that we could respond to that changing landscape at every level in the intellectual disability sector. And part of that transformation journey required us to become more aligned with the healthcare and the healthcare sector, because they're so, I would say from our perspective, that's really where you can make the difference in quality of life and where you can also see some of the outcomes and sometimes cost savings, which is one of the challenges when you deal with complex populations. It's a very costly endeavor, so government likes to cut it. Of course, none of those services can operate in isolation and work well, so they needed to be integrated together. And that really was our story. I know Sila will talk about that a little bit later. Now, a book on transformation, there were some key things we learned, which you always learn through transformation. We understood that it needed to take vision, and we had to needed a vision that took into consideration the need for Woods to help our sector build a real system of care for the people we serve, especially people with complex needs. We needed a strategy and a framework that responded to the ever-changing policy landscape and funding landscape to truly build an integrated and sustainable model of care. And we needed to build a culture of innovation at all levels of our organizations. We are an organization that's made up of a core organization and also affiliate organizations. And we needed to figure out how do we actually get to all of our staff and get their ideas and sort of bring that culture of innovation into the framework of how we operate. We needed to do change management, and we also needed to get the word out about what we're doing on new approaches, as well as educating our government agencies, funders, and policymakers about what we were doing, and also what we saw the needs, what we still see the needs are. So I want to do a quick plug for the fourth and final symposium that's coming up in April, and that again is around populations. There we're talking about strategies for avoiding the cliff at 21. Any kid in the public system, whether you're child welfare or even in our sector, intellectual disability sector, at 21, they go into the adult system. Some sectors are more lucky where there's funding streams, some are not. So we want to talk about models for education, behavioral, and also family support. So stay tuned for that, and we hope you will join us for that. With that, I will now invite each of our panelists to speak about 10 minutes about their experiences on the topic of complex populations. And I know they all care about it. And I'm going to start out with having Stacy DiStefano talk a little bit about her experience from more of the national lens. So, Stacy?
Yeah, appreciate that. Thank you. That's a great setup to this conversation today. I think I want to start with just acknowledging the evolution of our sector and our system, right? About 40 years ago, 80% of all care to complex populations was done in an institution, right? And today that's less than 10%. So while we've seen the focus on community-based care and community settings, we haven't necessarily seen the funding and the infrastructure keep up with that, which is one of the overarching problems in our industry. That evolution now with community-based care and more in-home and community-based services really also speaks to the social determinant of health factor, things that folks in our field have known about for decades, but policymakers and legislators and funders have only started talking about probably in the last 7 to 10 years in earnest, maybe even the last 5, things like food security, affordable housing, transportation, opportunities for employment, social supports, relationships, all of those things. We're starting to see now that health plans and managed care, and even with CMS, starting to work into payment structures to include those things when we talk about how to support people throughout the lifespan. So right now, about 80% of states have Medicaid that supports some sort of social determinant of health piece along with the care factor. And then interesting to note, 100% of the top health insurers on the private side are also including social determinants of health in the way that they fund services to folks. So when we think about the transformation and what we've seen across the country, we really are supporting 100% what Team said. We're looking at integrated care, right? Whole person care, integrated care, however you want to call that, removing the silos. So it's not one kind of service in one place. It's more of a vertical overall looking at the well-being and health of folks that we support, right? And with that, there's an enhanced relationship with the payer because you need more conversation about individual supports for populations, but it also provides a need for greater focus on the operational and business part of providing services. So in my experience over the years, we focused on mission, we focused on care delivery and personal supports for folks. But if you were a good clinician, you can kind of go up the ranks and become a leader of an organization. That was certainly my journey. I didn't have any business acumen classes in my master's of counseling degree, as many of our leaders don't. But what we're seeing now is a real intense focus on total cost of care. And that requires really knowing what is the unit cost of services you deliver. And then you can ask for enhanced funding when you know what it costs you to deliver that. So I say that to say, part of what I've seen across the country when working with clients in IDD services and other complex populations is that need to improve the business acumen with leadership teams, which is sometimes a real big shift for folks to think about. Especially when over the past few years, we talk about the pandemic and we talk about crisis and disruption. We're in a permanent state of disruption right now. There hasn't been a moment to rest and reset. We are constantly having to innovate and work through this. And I don't know that we will ever have that rest period, right? Until we continue to focus and think about how do we fully integrate services. Technology is certainly one piece, and I'm sure we'll talk more about that through the panel, but technology services, not just in the way that you manage the service, but in the way you deliver service, whether that's virtual reality, remote supports, smart homes, all kinds of things. But the idea of tequity certainly is something we see national, and tequity really just speaks to bringing the technology that we all on this call infuse in our day-to-day lives and take for granted, making sure that people we support also have access to those kinds of essential elements in technology, whether it's digital access or literacy or healthcare literacy, smartwatches, anything like that that we take advantage of. What I'm seeing is really making sure that people we support have access to that as well. So that technology in practice. I certainly can't be on a panel like this and not talk about the impact of private equity in our space, right? We have states like my colleague and friend, Chris Wolf, who's on our panel in Ohio, where 51% of the IDD providers in the state of Ohio are private equity backed. So those are colleagues / competitors that we can't ignore in our space. They operate differently. They are mission driven many times, but also profit driven. So we have to understand what they bring to the table. That's also a huge impact on our workforce development when sometimes private equity can pay higher than a nonprofit provider. So those are things we need to keep in mind. Interesting to note, there's 5,000 private equity firms across the country that have some investment in behavioral health. And by behavioral health, I mean not only IDD, but substance use, mental health, digital health, long-term care. 5,000 is quite a few. About 75 of those private equity firms have a major business vertical in behavioral health. So they are definitely here to stay, and they're one of our competitors. Certainly have ability to navigate with managed care. Again, I'm sure we're going to dive more into that topic with the panel, but with managed care comes value-based payment reimbursements and working with clients, large and small, right? It's not just scale that matters. Some folks in our space, especially on the IDD side of complex care, look at value-based care and say, that's a concept that doesn't apply to us. We can't do that. That's not going to work for us. That works in medical, that works in behavioral, but not for us. And others are seeing it as a real opportunity to impact the kind of payments they get and enhance that funding. So we've seen that all over the spectrum. What I can say about managed care and value-based care is while the rhetoric coming out of CMS and managed care is all about VBR and alternative payment arrangements, our regulatory process, our payment systems still have the fee-for-service lens. So providers are kind of stuck in that tension of, we want to be doing things with a more VBR lens, but the way that we're paid and the way we're incentivized is really still fee-for-service. So that's something we have to navigate. When organizations who are doing that successfully are really pinging more in on kind of those those BI services. You have to know not only unit costs, but your analytics, data dashboards. Value-based care is not something you can do on the back of a napkin with Excel. You have to have a much more sophisticated system to be able to do that. So really encouraging organizations who want to be progressive and innovative and treat people with whole person care to sort of get that variable payment that allows for whole person services, right? Because a straight fee for service is not going to do it. It's not going to address those social determinants of health and let you be creative. You have to have a little more flexibility in payment to provide a little bit more of a flexibility in service. I do think mergers and acquisitions are a big piece that we're seeing impacting our space. We're seeing lots of organizations, rather than organically grow, acquire other parts of their service line. So IDD folks, complex care folks, kind of adding on a behavioral health component, adding on a workforce component, adding on an ABA service, an FQHC, a medical piece, a health home piece. We're seeing folks who have a big platform in the space really adding on different adjacent verticals to create your own whole person care system within your organization. There's also some partnerships that are happening there, but I think the larger players in our space, what we're really seeing is, you have to build it to support the kind of service line and the service system that you want to see for yourself. And that's where you're seeing some leverage with funders and payers as well. But I can't underscore enough Teen's comments about that 21 cliff. I think that is something that we need to address, certainly as an industry with CMS and payers as well. The sooner that we start treating folks with complex care all across the spectrum, whether they're acute needs, whether they're light support needs, the better they'll be when they reach that 21 point. So as a system, I think we need to rebalance a little bit to see where we're putting those supports and services in, and then really creating a better continuum that allows for supports on the residential side all the way to supported living in a way that mimics a little bit more what we do on the mental health side. So the last thing I'll say in closing is when I looked at the clients that I support for the IDD services, what I hear most often is we can only support through funding because of the rates, the most complex and the most acute, right? The rates don't allow us to support the lower acuity folks in our programs. And that's unfortunate. When I look at the mental health side, certainly when I was running ACT teams many years ago, it's a balance of thirds where the best clinical outcomes and the best use of staff and the best avoidance of burnout was when you had a third of the people in your system with high needs, a third of folks in your systems who were fairly independent, and then a middle third who maybe bounced between. But what we're seeing now as an industry is a stress on the system of only the most acute folks getting the level of funding that supports a program. So we're kind of leaving behind the folks who need a lighter touch of support, and we're really taxing the system as far as burnout and funding. So I'll just sort of close with the idea that I think we need a global rebalancing to really look at a spectrum of folks on the continuum of needs and being able to kind of keep moving forward as a system with some creativity and funding.
Great. Thank you, Stacy. Great comments. Let's move to Dr. Musuneri.
Sure. Thank you, team, and thank you, Stacy. Your point is well taken about the cost effectiveness and having the business acumen in the leadership team. I always felt as the medical doctor, that's the part that was lacking. That's well taken. In a practitioner, actually, I'm a board certified child psychiatrist with many, many years of experience working with children with and individuals with intellectual disabilities and autism. Over the years, what I have felt is with the individuals working in the spectrum that there is no system of care really exists. What we have, the systems and services are very fragmented in the community. And the individuals with ID and ASD, they have multiple medical comorbidities and their behavioral challenges are complex. And the providers are not really trained to handle the ID ASD population. So a lot of times the psychiatrists are to manage the behavioral health challenges. A lot of times they end up on unnecessary medications. And, because of the medical complexities, there are many specialist referrals. And once they end up in the specialist clinic or in the hospitals, they end up receiving unnecessary procedures. And, that increases the healthcare expenses overall. There was one study that was published in JAMA in individuals with ASD and ID, they have almost 5 times more annual healthcare spending than the general population. And if you think about just the individuals with autism, the study shows that it's 3 times higher. So we are spending a lot of money. And, if you think about it, it's like a lot of unnecessary expenditure that goes into that individual's care. The integrated care models, we not only cut down the expenses, but we are also going to improve the efficacy and quality of the service that they receive. Let me explain a little bit about the Woods Healthcare model that we have recently. We are going in that direction. It is to provide access to the services at one place. And the medical center at Wood Services is the foundation for that integrated care. Through Keystone First, one of the Pennsylvania's Medicaid managed care plan, Woods launched the first ever patient-centered medical home for people with intellectual and developmental disabilities, autism, and acquired brain injuries. With PCMH, we provide comprehensive care management and follow-up over an individual's lifetime. At the medical center, we provide integrated primary care, behavioral health, psychiatry, neurology, radiology, and we do the phlebotomy and we follow up and we do the ophthalmology visits, and there is an ortho who comes as for consults. Recently we opened, we partnered with Penn Dental Medicine and opened a dental clinic on campus. It is actually within the premises of the medical center. So our residents receive their ongoing dental care on campus. They don't need to travel anywhere. Another neat thing about the dental clinic is that it also serves as the training site for future dental residents. So this is a valuable training experience for them. We are sending the, several of these dentists out with already experience in their bag working with the IDD population. Another expansion that is the exciting thing, we'll be opening up the Center for Behavioral Health Center soon in the next few weeks, also a Center for Autism. It is an outpatient mental health clinic especially for individuals with ID and ASD population. Will provide the initial psychiatric assessment, medication follow-up, as well as individual, group, and family therapies. One of the other things is we'll be able to do the initial diagnostic assessment for autism, which is going to be the startup point for a lot of these children who are waiting for an initial assessment. And by the time they get to the list, It's already, the time has passed. Early intervention services, which could have been started a lot earlier, they have been waiting for that. So that's the newer program, which will be opening in the next few weeks, providing it'll be open to the community as well. Overall, the psychiatry services we provide at Woods, whether it's our residential treatment facility level of care or our outpatient model, we'll be utilizing the more of an integrative care model, interdisciplinary treatment team approach. In the outpatient setting, it'll be more or less like a team working, a psychiatrist or a psych NP, clinician, family, care coordinators, all sit together and discuss the treatment plan that's more individualized to that client and family. And it's the same thing in our residential facility level of care as well, more or less with the residential manager, the client, residential manager, clinical team, the psychiatrist or the NP again, and the medical team, looking at the behaviors and trying to figure out why they are happening rather than just jumping to medication management. We work on trying to figure out the triggers for the behaviors and look at function-based approach to medication management, and also work on really looking at the variables, whether it's environmental, staffing changes sometimes can cause a trigger. They don't need a medication for that part. And it's the same thing in the outpatient setting. That's our overarching, model for a lot of interventions that we use to address the challenging behaviors or for the psychiatry medication management part of it. Coming to the complex medical and behavioral needs, there is another. It's actually a separate organization, Woods Community Services, 2 years ago, to address the needs of the individuals with the medical and behavioral complexity. We have community-based group homes. It's to improve the quality of care for the individual. A lot of times, otherwise they're stuck in the hospital beds. And because of the medical and challenging behaviors, and look at, you can just imagine if they are in the hospital bed for so long, think about the healthcare expense. We opened so far 4 homes, and we are serving 5 clients and several in the process, with multiple clients waiting for the bed to be open. We actually design each home with a person-centered approach and around the social determinants of health, just like Stacey was mentioning, taking into consideration the unique needs of each individual. There is a lot of planning and thinking going into these before we bring an individual into the home. There is a lot of our teams going into the hospital or wherever, whatever setting they were in, really work with the other team to develop a treatment plan. And these homes, we integrate psychiatric as well as clinical medical services are really wrapped around the individual. And these homes are also situated close to our campus, so they have access to all our on-campus recreation activities. And these 4 or 5 individuals are actually adults, so they come to our social enterprises for vocational training, and they are so close to the medical campus that they can seek the medical services, dental clinic, everything that, at one place. So that's one of the new programs that we have developed. One of the, we were just discussing about that one of the individual we have has had multiple restraints in a day, and we are successfully able to handle those behaviors in that community-based group home. Another individual we had, actually he's doing quite well. He's one of our first clients, came from a hospital he was there for 1.5 years in the hospital bed. So you can imagine that, it's definitely improving the quality of life. We are in the process of developing group homes for children. with multiple medical and behavioral complexities, who are really stuck in the medical bed, are in a psychiatric hospital with medical issues or intense behavioral issues. The medical complexities we are discussing are not, are not simple. Like, we are able to handle up to a certain extent in our regular RTF program. What we are discussing are these children who are on ventilation support for breathing, are on tube feeds, all those requiring multiple medical specialists. So each home will be built again geared towards addressing the medical needs of the particular child, with a plan to have a 24-hour nursing, medical, psychiatry support, and we'll be building a specialty medical consult network, and we'll be utilizing telehealth as needed, so that we can maintain him in a mini hospital home. And to maintain the stability, we will need to have, maybe to run it like a hospital with different shifts with the nursing and the doctor. So this home is also going to have an extra bedroom for the family, so that the parents can visit and stay if they would like to. So that's the phase we are going into. And just like Teen said, we are constantly thinking about bridging the gap in the system of care to provide those levels of care. To fill in those gaps, we do feel that the crisis stabilization and a step down from the inpatient hospital may be necessary. We are in the planning phases, but we feel that if there is an access or approach that where we can move the individuals up and down the levels of care, the family and the funder, and it's the whole person approach, but the teams will be prepared to handle those crises that do happen, and without really traumatizing the individual. Just to give you an example, in an RTF setting, an individual grows into a crisis, we don't need to ship them to the emergency room or think about an inpatient hospital. That's really traumatic for the individual as well. Going into a novel situation where there is so much of emergency rooms are not friendly. There are other things going on. But whereas if we have that option to step them up and down within our system of care, I think we'll be doing a lot more justice to that individual. So we are all, at Wood Services, just like Teen said, we are very innovative and creating and thinking about crossing those barriers to provide those levels of care to the individuals we serve and into the community.
Thanks, Malu. Melissa?
Thank you so much, Teen. I'm so glad that we're having this conversation. And I think that a lot of the other speakers have already touched on the fact that, this isn't an easy discussion to have in terms of how we provide and deliver care, complex needed care for populations who need and deserve it. And, as we're talking about this, and I'm going to kind of pivot to my PowerPoint in a moment, but I just wanted to touch on the fact that when we're talking about this, and my perspective is a little bit different from some of the folks that we've already heard from, because of the population we serve. But the way that we need to think about complex care, actually, I'm going to encourage us all to be a lot more expansive. And what I mean by that is how we're engaging partners and helping to fill in some of these gaps, how we're engaging community-based organizations to be able to deliver the aspects of care that perhaps we cannot through reimbursement or procedure or whatever that is through our own internal processes where we have those gaps. And the reason I say that's important and that we truly need to think about that differently is because I was just looking at this recent report, Teen, from the NCHS, and you've probably seen it as well, where we're looking at the health disparities, as of Healthy People 2020, and there has been little to no overall change in a decade for populations we're serving, for where we're seeing disparities. And a lot of these populations we're talking about have been historically marginalized, have not had, historically underserved, and you're seeing them in some of these same places over and over again. We're seeing them in the overutilization in the ED. We're seeing them in the, having the not access to the resources that are necessary. And so when we see those statistics and those hard numbers, it should make us question as providers and as a system, where are we breaking down because we have the services available? So I'm going to just talk about that, and I'm going to go ahead and transition to my screen just to make sure I keep myself on time here, to just really speak to what that could look like and how we're approaching it at Ascenda. So we, as it starts here, it does say community-centered and compassionate care, and I can't underscore how much the community-centered piece is important and how significant it is, because if we are not understanding the needs of the communities that we serve, and I'm not speaking just broadly communities, and I think one of the other panelists said this, I'm really speaking to the local level and having the local voice engaged and involved, because often there are barriers that we don't know and we don't see as providers. We think we understand what the needs are, but then when we unpack and uncover it, we realize that there are some barriers that we did not expect and that we're running into without intentionally causing an issue for these folks who need this very complex delivery system. So this is just kind of high level who we are and how many programs and the many individuals we serve across New Jersey, which we're honored to be able to do so. And these are the programs that we provide. And the reason why I wanted you just to see this here is for you to understand that we are supporting some of the most vulnerable communities, vulnerable individuals and families in the communities we support. We are providing general counseling, CCBHCs, early intervention support services, maternal health, child and family services, juvenile justice. So across the spectrum, but what is consistent across all of these is that we understand as Ascenda that we are not able to carry the full care of everyone on our shoulders, nor should we be expecting to do so. If we are going to reduce the amount of disparities that we're seeing in our communities and ensuring that the folks who deserve and need it are getting the care that they need, that means reaching outside of our walls often. So that means if we're encountering and experiencing a family who is coming to us for mental health supports, and we're truly saying that we're providing holistic care, it's not only understanding the need of that individual, it's also understanding the needs of the family and where their family might be. And if the family is battling, and we talk about SDOH, and forgive me, but sometimes I hear when people talk about that, I swear that it's just kind of this throwaway term that people have learned to use and think they should inject it whenever we're talking about care. But if we're truly going to look at SDOH and how we're supporting not only the social determinants of health, but those structural determinants of health, that means that we need to be looking at how that family is able to get themselves to the appointments, how they're able to sustain themselves with nutrition if we're talking maternal health. So there's lots of components and aspects that are involved there that we challenge ourselves to think about at Ascenda, and I know a lot of our peer providers are doing it as well. Is it easy? Absolutely not. Are there aspects of it that are not reimbursable? And I think you heard Stacey speak to this earlier, 100%. But are there opportunities to find and partner with others who are able to do that and align in a way that provides a stronger and better support than perhaps we're able to do on our own? Yes. The answer to that is yes, many times over. So this just kind of speaks to, again, at Ascenda, we're really looking outside of what is kind of historically, typically, what an organization like ours would do in terms of the needs of our communities. So when you see here, when the state made the call and, we understood that within our communities, there were many homeless who were vulnerable individuals who were not getting access to the vaccination. So we said, okay, so how can we help to step into that gap? Because we know that if they're not getting vaccinated, if they're getting ill, then that could potentially impact how they're able to access these other services. If the main caregiver of the family comes down with COVID and is not fully vaccinated, then that's going to affect their ability to support their family. So then you're looking at economic impact. So that economic impact then can lead to some mental health issues. And you see how all of it is truly connected. So again, getting involved in these different initiatives, not only at a statewide level, but also at a regional level, and even sometimes plugging into that thought leadership at a national level. I know this is something Team does extremely well, and that she and I have talked about frequently, understand what's to come. What are the trends? What are folks doing in other states? What's happening that's potentially impactful? Perhaps we can bring it back to our state here, or even some of the counties that we serve, but it's important to have a lens that is much more broad, not just in terms of the care delivery system that we're delivering locally, but it's broad in terms of tapping into the knowledge base that's available on a much, much larger level. So this is just kind of just a hodgepodge of some things that I wanted to just touch on in terms of, what I mean when I say kind of looking outside of the box. Now, some of these are established models. Of course, you see these integrated care delivery system, integrated care delivery models. And it's funny that I had that there because we approach everything at Ascenda as though it is part of an integrated system. It is, even though there's a single program that is designed to be somewhat self-contained, we are expecting that the folks who are in that program and our teams who are leading those programs are linked into the rest of what's going on at Ascenda. So that that family has a need that's beyond just the scope of that program, that we're able to connect them wherever it's needed. And that is what a true integrated care delivery system should be. That being said, so we do have these models that are very, very complex. Certified Community Behavioral Health Clinic, again, very much self-contained, intended to be from a data standpoint. I heard someone mention it earlier. It's critical to have these data visualization models that are modern, and that they're responsive, and they're malleable to the needs of the organization and the community. So we have many of those that are in a part of Ascenda. We have these co-occurring SUD program, recovery programs, programs for the serious and persistent mentally ill, adult partial care, psychiatric emergency screening services, path for the homeless. So we have those as well, where we're going into the communities and supporting individuals with these high acute needs to either, support them, whether it relates to homelessness, whether it relates to emergency room utilization, any of these other things, making sure that they're staying adherent to their medications, adherent to their treatment. We are in the communities with them to engage with them. And even as we're doing that, we are ensuring that it plugs back into a larger system of care, supports, and partnership. It cannot stand by its own, and it should not stand by its own. There are a couple of violence intervention programs that we are now doing. Again, may seem like something that is outside of the scope of what an organization like ours would typically do. However, what I would say is it is very much a part of it. And we're talking about, violence, community violence as a public health issue. Those are affecting the communities that we serve. So we cannot take a narrow view as in that is just, someone else's issue. No, these are our family's issues. So we are going to get involved and support and work with other partners in terms of reducing violence, making sure that we're providing trauma supports, making sure that we're providing mental health guidance, connecting to, with our law enforcement partners, with our hospital partners, and ensuring that these families have what they need. So to not only deal with the specific issue that's occurred, but also maybe some of the underlying issues that are contributing to them being involved in the violence in the first place. And then we have our family-based services and supports, which are really designed to have a much more broad view. We're working very closely with the state of New Jersey. In many cases, we're working very closely with our schools. We also have some prevention programming where we're engaging with families to prevent them from going into any sort of, foster care or being involved with the foster care system. And we do that through these retail-based models through our family success centers. I believe we have 8 or so across the state. So all of these, and what I'm just really trying to emphasize here, and from Ascenda's view, is when we're looking at this and we're looking to have partnerships and other organizations like ours, we have to be, at the table and bringing other folks to the table, and not just having a very narrow lens of this is just what the medical approach, or this is just kind of what the current reimbursement, even though those are critical. How do we engage some of the other partners to be able to fill in some of these gaps that exist? Because if we don't, we're going to continue. We're going to have another report from NCHS another decade from now, and the exact same disparities will be there and cost everybody else the same. So just in terms of how we approach our partnership considerations, this is what we go through every time. Is there an alignment of mission? Are they focused on the same things that we are focused on? Is there an authentic commitment to community? And I say authentic here because, we've talked about there are some folks who are coming in and out of our space, in and out of the space that we're in. We want to know that they're sustained and that they're committed. There's their operational excellence, obviously, because we want to ensure that the folks who are coming through this system continuum that we're creating, that they're going to receive the highest standard of support, this cultural relevant care, and that they're going to be treated with a reduction in bias and be welcoming and barrier free. And then also, is there an urgency to action? Because we don't have time to continue, and our families don't have time to continue to wait for us to figure this out. There are many of us who are sitting in these rooms and these think tanks and talking about what could be done and what should be done. And meanwhile, there are families and communities that are dying and that are hurt and that are continuing to wait until we figure it out. So there needs to be an urgency to action, and that's how we approach it. So team, that's my story, and I'm sticking to it. But that's kind of our view from a Cinda standpoint.
It's awesome. And full disclosure, Melissa and I have worked together for 100 years, and no matter where she goes, she's got the broad brush. I mean, so key on community, and really, excited to see what you guys are doing at Ascender. So great. Last but not least, we're gonna have Chris Wolf talk about what he's doing.
Hello, good afternoon, everyone. It is always great to be last after a whole group of amazing folks, because they've said most of everything. So you could kind of listen, what they said, right? But I'll take a little bit of try to find some gaps in there and talk specifically about our journey and our how we've kind of gotten from point A to point B. And I'll tell you a little bit about what was point A and where we are at point B. So Boundless is an organization right now that's based in Ohio, and it has a pretty long history, about a little over 40 years in the nonprofit space. Actually came out of a local local county government arm of residential services. And when our current CEO found the company, they found him and came on board in 2015. We were serving one county in the state of Ohio, which has 88, and serving about 200 folks in residential programs. Forever, we have been, our legacy, as we like to say, is in the IDD space. They were, as a residential provider, the group that would serve those that could not be served, right? So the county sort of had that in their pocket. Okay, if we have something challenging, this is the group that's going to do it because it's our group. Well, then that group privatized. And for several years, it just kept sort of doing its thing. Well, let me tell you where we are today, and then I'll talk about the journey. Where we are today in 2023, we now sit in 55 counties, or I should say we serve folks in 55 counties. We do have offices across the state. Instead of serving 200 folks a year, we're close to 5,000. We now have a little over 2,000 employees, and revenues have expanded from around 25 million to a budget of 100 million this year. And the journey, or what did that, if you will, I'll get to all of the things that did it. What I will say is it started with the idea and understanding that what was missing wasn't necessarily more residential services or more traditional services and more typical services for adults with developmental disabilities, but to realize that our mission as a nonprofit needed to expand in age, in space, and in comprehensiveness. We really were providing some of the more traditional, certainly waiver services in the Medicaid world, but also intermediate care facility services. It's very residential, but we were totally missing areas, whether it be dental, behavioral health, primary care, specialties, you name it. We were that traditional, almost 40 years doing that DD provider. And by saying what we wanted to do and kind of building that road and saying we needed to acquire some behavioral health expertise because we knew the folks that we served needed to be served better in that space. That led us to an acquisition that brought in both a tremendous amount of expertise in autism and behavioral health, but then that led us into acquiring employment programs and things of that nature. And as a nonprofit, I like to joke. So I have a lot of experience in the for-profit world. And acquisition and merge is really, really tough. It's tough, period. Don't get me wrong, and Stacy can tell you that. But it was pretty amazing to see organizations merge together and have these resources, as opposed to necessarily having to figure out what the price was and the EBITDA and all these different things. It was a very different transaction. The first one I did a nonprofit, I said, this is amazing. This is truly amazing, where we have organizations coming together because of the mission and expanding what can be done for the folks that we serve. So as I said, it really was based on this idea. It didn't start with, we want to become very large. We want to grow. We want more, revenues. It really came down to impact. And what I want to say to everybody here, by pursuing that impact, the things that you hear from the Woods and what Teen and her group are doing and saying, and Melissa and everyone else, that this is not only something that ethically and morally we believe in. The time is now. It is actually, people are gravitating and saying, oh my gosh, how can we get more of that? And so let me talk a little bit about the partnerships and different things that we found along the way as we've acquired expertise and we acquired these relationships and developed additional programs and really focused on outcomes. The partnerships have been huge. And in fact, what I wanted to say is sort of a best practice. We'll talk about some specific things either here, or I'll try to finish up here closely so we can get to some questions. But I got to tell you, if you are pursuing integrated whole person care, which is what we started in 2015 as what we were pursuing, a best practice I'm going to tell you right now is going to be talent. And then the second thing, you heard Stacy say this, in Ohio at least, and I'm sure it's in lots of places, you have a lot of private backed, you have equity, you need money. And what I mean that is you need to be able to invest in things. Everything we're talking about is brand new. Like the need has been around forever. I think Melissa was saying that, right? The need's been here and we keep seeing the reports and what have you, but like how we're solving it and actually putting, rubber to the road and making things happen and changing and adding new therapies or treatments or ways in which we approach stuff, it takes some money to invest in that. And if you don't have the cash, you've got to find ways to do that. But more importantly, you've got to have talent. If you are an organization that's been around for a very, very long time, you've got to make sure you've got leaders that are happy to think about something different, are happy to think outside their silo. Again, in the DD space, what I would tell you is that we sometimes are challenged by the fact that we're usually the last group that anything gets impacted, right? We kind of sit back there and first it's usually children or mental health and addiction and, you name it, even aging will get nailed before DD suddenly here it comes, right? We're waiting for when managed care comes. In Ohio, it is like 99.5% of the entire population is mandated if they're on Medicaid to be in managed care, except you got it, the IDD space. So, but it's coming. And again, just looking at the time, what I'd say is we understand that the ultimate goal with whole person care, integrated care, is also to look at value and to be able to measure that differently. And I was telling a friend of mine the other day that works at the state, we were talking about some programming they were looking at. And I just said, listen, if I can stop chasing units for the back half of my career, that would be an accomplishment. I'd like to chase outcomes. I'd like to chase impact. But right now, you got to be smart and chase the units. And we do a lot with this integrated model where we're bringing down different funds. And it was really challenging for folks until you really express these are all things that this person is eligible for. Don't stick them in one system and say this is the system that's supposed to solve it, right? And probably the last thing I'll leave you with, just again with attention to time, we really leaned into in the ability to communicate what we're trying to do. We leaned into that our IDD traditions, if you will, are social determinants. We're all about, food safety and housing security and employment and integration with the community. That is a legacy that we carry for decades with regards to the DD community. So social determinants, we need to grab that and say, oh yeah, we own that. We've always owned that. That's not hard. Now these other components, now when you bring that together, you've got that trifecta. You've got primary care, you've got behavioral health, you've got social determinants. How do we bring it all together? I'll say one last thing, which is I heard Melissa and I think others say it as well. We're excited about the things that we do. We love growing and expanding and creating more comprehensive services, having interesting pilots with managed care programs, with the state, with hospital systems. But we also believe we can't do it all ourselves. So we like being able to create these things. But when we go in around the state, we really are looking for gaps. We're not really looking to suddenly say, we'll be everything. If you've got this and it's great, well, then let's partner with that. What don't you have? Let's come in here. And I can tell you that our public partners really appreciate that we're not trying to come in and just simply say, well, we want to do everything because, well, why not? Right. And why not is because there's a lot of people doing good things. right? So let's find the gaps, let's work together, let's really kind of figure out all the elements necessary so you can pull that whole person care together. So just as for a time, I could keep talking, like I know everybody can, but I'll pause here and let us move on through the program. So.
Thank you, Chris, and thanks to everybody sort of for opening it up. And really, I think both focusing on the intellectual disability, autism, and the behavioral health space. And for us, it's it's all integrated. It's the populations on a continuum, but I think all of us face issues in our communities around the country and our regions. So I have some questions of our panels, but feel free to to put some questions in the chat, and Liz will help sort of look through those questions. Again, we want to hear from you as well and get some of your questions answers. But Stacey, I want to start with you. I mean, you have such an incredible background from the executive, being part of a trade association, now doing consulting, think tank work, you name it, and you work with essentially the private for-profit in the in-between sector, as I call them. I think Chris talked a lot about sort of you've got a hire that's already close to managed care. At least you were there. If you've got private equity, we know that it might be one of the first, right, to truly go managed care and thinking differently about how to pay for services. So in terms of Stacey, if you could just talk a little bit about what are some of the ways that I would say both the intellectual disability, but also the behavioral health sector, you work with both, need to think about value-based care. How do we prepare for it? You touched a little bit on it in your beginning statements. And also, what about the idea, as Chris pointed out, and also partnerships that that Melissa talked about, how do we look at maybe more consolidation in the marketplace? What do we need to do in this broad, behavioral health, intellectual disability sector to think about, preparing ourselves to be ready? Because I'm also fearful when Chris said what I think, especially on the intellectual disability side, but also the Ascenda side, we do everything. We have the social determinants and the health piece. This is what is now functioning anywhere else in this country. Versus socialized countries. So we have it, we don't want to lose it. And I could see very easily how some of that could be picked apart if a typical insurance managed care sector would come in and just pick it apart in silos. So Stacey.
Yeah. God, I mean, there's so much to dissect there, and you could talk about just that question probably for a whole symposium. But, I think starting with managed care, right, nationally, we're trending more to managed care, whether we like it or not. So Pennsylvania has a carve out right now. Other states have a carve out. I've said for a long time, I think we'll get to a point where there's no unmanaged care. But we want to be clear about what we're managing, right? So you're managing provider contracts, you're managing funding, you're managing utilization, but we're not really managing care. Our system is a long way off of actually managing the care for people. And that's where the red flags come up when you talk about complex populations. To your point, Teen, our system isn't nearly sophisticated enough to actually be managing the care. And that's where we get concerned, right? There's a wide range of failure and success stories when you look at states who have managed care. If you look at Kansas, you look at Iowa, that is the poster child for what you should never do to implement a managed care system, especially a full-on with IDD population. But then to be fair, you look at states like Arkansas, like Tennessee, where, even North Carolina is still struggling to get the tailored plans up, but slow to ramp, but really good intentions, thoughtfully done, forward thinking. So I don't want everyone to be fearful of it in and of itself. I think there are some ways that it helps the system. One thing I will say that providers need to be on the lookout is with managed care comes increased consolidation, right? You just think of that from a practical sense. Managed care does not want to contract with 150 small providers in every state, right? They want to have maybe 10 or 12 contracts with systems of care, with partners of care. So that doesn't necessarily mean we're going to have all of these small providers collapse into others or kind of fit or dovetail into others. That's going to be a big piece of it. And the market has shown over the past 3 years, consolidation in our space continues to go up with a huge peak in 2021, right? So we can see that still happening, with the deals that we see closed. So that's going to continue to happen. So I think the overarching piece is you cannot keep doing what we've always done. Right? As organizations who want to be not only sustained, but thriving in the next generation, you have to think about in the future, what will it look like with managed care? What will it look like with value-based contracting, right? How do you prepare yourself now in small increments to get there? It's not a flip that you switch. And in the businesses that we run, it's not a factory. We can't shut down so that we can prepare for something in the future. We have to be doing that in baby steps all along to get there. So the biggest thing I would say around those two topics is start to prepare now for what it will look like, and make sure the leadership team and the board are the teams that you need, right? Sometimes the team you have is not the team you need. So not only bringing in consultants and outside SMEs and other folks to prepare you for that, but partnering with organizations who are already doing that in some way. But moving forward is the only way. If you are locked in and you dig your heels in and say, we're not doing it, I guarantee you won't be here in 5 years to tell me that story.
That's a great point. And that sort of makes me think about Melissa in terms of thinking about Senda going across the state of Pennsylvania, and a little bit to Stacey's point. I mean, you got to have the right people on the right side, you know, on the right sort of seats on the bus, et cetera, and also the right infrastructure. So could you talk a little bit about how you've gone about sort of building that, you know, both the staff up, you know, the training, the support, and also the infrastructure for your supports and, you know, your programs and supports to serve this, you know, more complex population?
Yeah, and Stacey just touched, I mean, she touched on some amazing points there. What I would say is, as we're approaching and as we look at our infrastructure, we intentionally designed it to be nimble. We designed it to be regardless of how large we are. So everything that we've done has been through this lens of, if we were across 5 states, would this work? You know, if we were serving all these different types of programs, would this work? And the reason that we did that was because we understand how the system is changing, how things are changing, but then also that we need to be ready for things as they come. So, you know, one of the first things, of course, that we focus on is staffing. And so this is, you know, I think Mike said it, Stacey said it. This is also one of the toughest areas, right? At all levels, because not only do you want to make sure that you have the right people in the right seats on the bus, but you want to make sure that you're training them and supporting them for what is going to come. You know, it's not easy to fill certain positions. Right now, we're filling it across the country. We're definitely filling it in the state of New Jersey. So we're making sure that we're keeping pace with market. So that's one area. We're focusing a lot on staff. The second area that's probably one of the most important is our data infrastructure. So we've invested a lot in ensuring that we have the proper data visualization tools. So we use Power BI. So we use Microsoft Power BI. We also have a number of other different systems that we use internally. We have an EHR that is fully, you know, we use Cerner. So Cerner is able to integrate with our hospital system partners. We're a part of a number of HIEs, so that it's all built to be able to communicate and connect, but not only communicate and connect, because we talk all the time about, you know, and everybody, you know, who's in data knows this, you want data to be, you know, information to knowledge to wisdom. And so we need to be able to capture the information that's going to allow us to do that. And so that means that at every entry point, we are tracking at an organizational level KPIs tied to, are these data points being collected? We at our orientation for new staff carve out a part of new orientation, new employee orientation, where we're specifically speaking about the importance of capturing these data points and how it not only ties to, you know, it's not just the busy work, but it ties to how we're creating programs for our community. So we use that to tap into how our employees feel about their mission focus. So data and an investment in data on all different levels is something that we have been particularly mindful of. And then, you know, COVID changed some different things in terms of facilities, but I would say that the data infrastructure and staffing in terms of training, et cetera, is a big part of how we positioned ourselves in terms of infrastructure.
And Silo, can you talk a little bit about, you know, also the provider side, which is how we, you know, how you and the teams are influencing training, preparing the next generation of providers, because I do think that this is a different level of care in that whole spectrum. And I would say most of our medical, nursing, I would say even social work schools don't really, I would say, go into the complex side. It's not part of the core curriculum. So I think it's kind of on us as a sector. So maybe touch a little bit about what we do here and what you've done before and sort of your vision for some of that.
Sure. You're right that actually there is a study that just came out again. It was published that psychiatry residency programs and child psychiatry fellowship programs, they don't have enough exposure to the IDD population. They may have certain classes in the first year or second year, but the number of patients that they see is negligible. And, we strongly feel that the next generation child psychiatry fellows or the general psychiatry residents are the psychiatric nurse practitioners. They need to have that exposure during that training because this population is quite unique. They present with the challenges of their own, and mainly because of the lack of communication, sensory needs, and maybe there is another medical issue that's going on. And their presentation of the psychiatric symptoms and behavioral symptomatology is quite different from the normal population. The medication interventions are also quite different. Working with this population for so long, I have had my burns on my hand. Sometimes every individual is different. They respond to lower doses of medications, and they may react adversely to certain medications. So that knowledge and expertise are the At Wood Services, we have developed a program. The Psych NP students, they go through the preceptor with us, and we kind of have them rotate through different scenarios or the complex cases, and also being a part of the interdisciplinary team and psychoform, kind of like exposure to what they can use, and they are a part of the team. So that's a great experience for those psychiatric nurse practitioners. We also have child psychiatry fellows doing a 1 month long rotation with us, as well as the general psychiatry residents. I think the limited training definitely has an impact. We see that all the time, that the psychiatrists with no experience are not having enough exposure to IDD individuals, may end up using more medication, the polypharmacy, and also not, looking at the behaviors, why they are happening, or quickly going to the medication as the treatment option. Another thing that we come across all the time is that when our individuals go to the emergency rooms or specialist appointments or medical appointments, we see that all the time. Those staff or the providers are not, even the office setting itself is not able to handle IDD individuals. There is definitely a concern sometimes, if they're really receiving the appropriate evaluation and care, because sometimes these individuals in the emergency room can be disruptive to the other, patients who are there for acute medical emergency. They're quickly being discharged out of the emergency room. In my opinion, I think there should be IDD training for all the major hospitals, health systems, and outpatient clinics as a part of their staff training. That's really important. March is IDD Awareness Month. I feel that there should be some inclusion and training involved for everyone who is in the sector, health sector.
That's a great point. And actually, again, go back to what I said earlier, having come from the healthcare sector, moving into the intellectual disability and autism sector, and realizing it accounts for $880 billion of the Medicaid spend, and never thought that. I mean, I realized that even though I've been in health policy, I've worked with complex populations. It's a population that is a small end but a high yield, and we all need to understand that with population. So we talked a lot about both the systems, and I was saying Elizabeth did a great job on the community, the connection. We talked about sort of the infrastructure, we're getting the right staff, preparing staff. Let's talk a little bit about families. And Chris, I wonder if you can just walk us through, and we have family members I know that are on the webinar. Can you talk a little bit about how you help families navigate and sort of finding the right kind of care? Because it really is about connecting people to the right touch points, the right care points in that system of care that you're building.
Yeah, happy to. So we opened up our primary care clinic in basically the beginning of 2022. And since that time, we've seen a little over 550 new patients come through. So just talking a little bit about primary care for a minute and connecting with the community. what we found there, we were already serving close to 2,000 people, and lots of them with the families and living at home and all of that. And actually, when we opened up the clinic, we actually thought this would be very easy to get the message out. This is going to be, we developed a space that was specifically designed with people's needs with regards to sound and space and light and just all sorts of things. It's a tremendous space. It's a tremendous clinic. And what we found were families had found their primary care doctors, and though they may not have been incredibly satisfied with them, the journey for parents over the lifespan of their loved one is so tumultuous that if they've got someone and they're willing to work with them a little bit and just sort of help, just if they're willing to work with them a little bit, I'll just leave it at that, they'll stay. They're so fearful of losing what they know versus what they don't know. And so just to talk for a minute about even engaging with families in our own community about the new space, and we brought in a medical director who had background in this with special populations. It wasn't someone who didn't understand working with someone with a disability. And yet all of those things, here's the space that's created to be inviting. Here's the professionals who have background and experience in this. It's still a conversation you have to have with families. And then it goes beyond that. As you kind of talk beyond primary care, we have several different programs through our mental health clinic that we are absolutely engaging with the community and coordinating and just sort of evaluating. Something that's very underfunded, but something that we do that's really needed is an early identification clinic. Now, we have lots of families. So again, not talking about the family members who've been out there trying to find medical professionals. Now we're talking about folks who are trying to understand what's happening exactly with my son or daughter. And they find that very difficult to find someone who's willing to put the time and effort and the specialty that usually takes psychiatry, that takes speech, that takes medical to really do a proper evaluation at a young age. So lots of different ways that we try to connect with families. I would just say that most of them need time. It's very confusing. It can be, depending on where they are, very scary. They could also be just very burned out. As I said, like, we've got somebody, it works. We're kind of done with that journey. We want to put that behind us. Hopefully that kind of answered your question there a little bit.
That's great. So Pam, Dana has a sort of a comment, a question, sort of saying it's great to provide exposure and training of the medical professions and with both IDD and special needs. How do we as experts get compensated for developing and providing this training? So just on the policy front, we have Kristen Ferry, that is our VP of Government Affairs here at Woods. I'll have her talk a little bit about some bills that are floating onto the mock bill, et cetera. But I think on the intellectual disability side, it really starts with recognizing the population. There is a whole system within the federal government and under HHS called Health Resources and Services Administration. That's where all the GME, graduate medical education, and the graduate nursing education and all that, those dollars follow. And one of the challenges, at least we've identified, has been if you're not recognized, if you're not called out as a population, there are no special, I would say, trainings. It's just part of the general education. Now, if you are in training programs, if you partner with universities where there is funding, in some cases you are able to get reimbursement as a site, et cetera, but that doesn't exist unless the populations are called out. So we've thought a lot about what we need to do at the federal area to put some attention, especially on this complex population, the intellectual disability and autism side of the care. So Kristen, if you just want to sort of call out, because I think there's some bills floating that just some of the folks in this audience might want to know about that we are trying to get support for.
Sure. And I think it's a good opportunity to also speak to, the exposure of the medical professional involvement in IDD to policymakers and, the welcome that we've received from legislators and policymakers from this type of integrated model that Woods has been demonstrating. It makes a lot of sense from a funding perspective, from a cost saving perspective. And I think that, folks developing Medicaid legislation like to hear that, as well as they also like the human aspect of everything and making sure that folks are receiving, the best care possible in the setting that's most comfortable to them. But I think, specifically, we've been working at the federal level with Congressman Brian Fitzpatrick and Congressman Seth Moulton on the Heads Up Act for the last couple legislative sessions. That has not yet been reintroduced, so I don't have, unfortunately, a bill number to tell you to all reach out to your legislators. But if you say, support, co-sponsor the Heads Up Act, sponsored by Congressman Moulton and Congressman Fitzpatrick, they should be able to figure out what you're talking about, because it should be reintroduced here within the next couple of weeks. We're looking for one more co-sponsor on the Energy and Commerce Committee, so we're almost there. But specifically, that bill would create a MUP, medically underserved population designation for individuals with IDD. Now, you guys are all health and human services experts, so I'm sure you know that MUPs are traditionally based on geography primarily when it comes to underserved populations. So we're coming at this from a unique angle, but I think there's recognition of the need that regardless of where a person with IDD, especially if they have medical and behavioral complexities, regardless of where they live, you can live in Center City, Philadelphia, you can live in Elk County, Pennsylvania, and you're underserved just because there's not a lot of incentive for medical providers to specialize in your care and your needs, and the Medicaid reimbursement is certainly not an incentive. So the Heads Up Act would create that designation, help increase reimbursements for providers who want to specialize in this type of care, help eliminate some of the red tape for establishment of clinics and practitioners to really specialize in that population. So we're excited to be building some momentum for that bill this session. So please keep an eye on it. And if you're talking to your Congress member about anything else, please mention the Heads Up Act. We'd love to get additional co-sponsors.
President. And we always, have an extensive involvement in education and policy involvement. So, and I think one of my sort of messages for all of this is we control that. I mean, our policy, it's where it's all at. Politics is where it's all at. And sometimes, when Chris said sort of who goes first, and when you cut programs as kids because they have no votes, no voice, right? I would say the sector, at least on the autistic intellectual disability side, you've got some strong families, and I hope those families will continue to be strong, because it is about that voice and being represented. But I think we can do a lot more, and I think that as we go into that more of integrated care for this more complex population, as a community, medical human services, we need to get a lot more engaged, a lot more ready for that. And that leads me sort of to Stacey, if I could sort of just talk a little bit about, what are some of the takeaways for the audience to grapple with some of the pressures from the state, federal government. So, how do we prepare ourselves? What do we need to think about? What are some of the models that some of the organizations might have to think about, both on the intellectual disability, autism side, and also the behavioral health side?
Yeah, that's a great question. And I think part of what I would say around program innovation is looking at populations that are underserved within the underserved even, right? And try to look at what can be built based on those needs. So one of the examples I have, and this is just something that I think is so right in front of us, is the aging baby boomer population, right? And they are supporting often at home adult children with disabilities in their care. And as they continue to age, right, where will the folks that they are living with, when their parents die, where will they go? These are folks who have never been in supported living or any institutional setting before. They've only been at home with parents who are now aging. So I've seen some work done around providers who are looking at a community system, almost like an assisted living program that also has a component to support the adult child with disability. Why wouldn't they live together in a family unit in a supported setting? I think there's great opportunity to think about that population. It makes so much sense to me. I think as the hurdle we have as a system is we've yet to overcome who's paying for all the parts of that, right? Those are very siloed when we think about that. And that's the piece I would also tie in naturally around the value-based care or the bundled payment. When we look at the folks that we support, it's a wrong pocket problem for us, right? Because value-based care and any enhanced payment model, pay for success, is really predicated on saving on the acute side, saving in the emergency room diversions, saving in hospitalizations. Those savings don't impact us as providers of complex care. Our rate is our rate is our rate, whether someone's in the ER or not. And so I think what we have to really press on as a community, and we can do this individually as well in our own regions, is, to kind of look at a shared savings model, to go to a funder, to go to the state, to go to CMS and say, look, if we save you money on these 100 folks who typically cost you a lot of money, we should be able to share in that savings with you. We're not doing it as a favor. We're doing it because we want enhanced rates so we can do more on the front end to keep folks out of the ER. So I think that really is the opportunity, is the forethought and the pressure on where that saving is coming from, and trying to get kind of our hands in some of that so we can really bring it back to our own.
That's great. And Melissa, and you such a, I would say, focus on sort of the children, families, and at the community level. What do you see? I like what Stacey's saying, let's be proactive. What are some of the greatest needs you're seeing and opportunities for that population?
Yeah, youth mental health, that's one. And our growing youth mental health crisis and everything that comes with that. Again, if we take that holistic view, there are many impacts to that. If you see increased rates of depression, suicidality in our youth, there is an impact to the family unit. So then what does that mean? And what does that mean in terms of economic stability in the family? If the caregiver has to now be pulled away either to take care of the child or to pay for the child and the child's treatment in a way that they haven't, they can't afford. So I think that's a significant issue. And that, to Stacey's point, if you look with, communities within communities, because even though that rate is extremely high, if you look at Black and brown families, Black and brown youth, especially, young girls, the rates are even higher. So I think that's a significant issue. The other issue that I believe that we need to be preparing for and getting ahead of is the end of the public health emergency. Now, it's funny because, when I talk to people, they're like, oh, well, a lot of things that were in place are going to stay in place. Telehealth will be fine. But, the redetermination and folks dropping off the rolls will have an impact. So if you think about it this way, where before the pandemic, there were people who were there were disparities that exist, as we talked about. There were people who weren't accessing care. There were people who we saw significant illnesses and disparities in terms of chronic physical and mental illness. And then the pandemic hit. And as we all like to say, it exacerbated or brought, existing issues. Now, you're going to have some of those folks who, through the redetermination process or just different administrative churn, will drop off of the rolls. So then what does that now mean in terms of their access to care? We have some areas, New Jersey is one of them, where there aren't a lot of physicians who accept Medicaid patients anyway because of the differences in rates. So now you have this problem compounded on top of problem in the midst of a mental health crisis and significant higher levels of need right as you're ending a public health emergency on May 11th and people losing access to coverage. So I think that's something that we need to be preparing for and getting ahead of as community partners and providers.
Great comments. So I'm mindful of time, so I'm just going to ask each of our panelists just to sort of give us some sort of closing comments, thoughts, and I'm going to start with you, Chris. Things you want to share with the team.
Yeah, thanks. I think what I'd share is some concerns or fears that I have. Like right now, there's a lot of attention on workforce, which is great attention. My fear is that it's really focused on just having people. Right. So the worry is, well, I don't have enough therapists to do intervention. I don't have enough folks to do crisis. I don't have enough staff to support someone with direct support professionals with developmental disability. And that is correct. However, because we work with legislators, I believe that what happens is that we are going to advocate for dollars. We may even get some dollars, but what we haven't solved is which Stacey said very nicely, we have a witch pocket, or I'm going to say that wrong. I'm not going to say it, but basically, we're still trying to solve our problems by not looking at it globally, not looking at it integrated, not looking at it whole person. We will never solve our challenges if all we're trying to do is deal with our current system, our current structure. And what I worry about is we have all this momentum with regards to workforce. But what are they then doing? What's the purpose of the workforce? And how does that integrate? And how does that become actually a solution? And the idea that when you go to a legislator and you get a large bill that gets passed, and then you kind of go, oops, I still need more. They don't like that. they don't like to listen to that 2 years later, because they kind of go, wait a second, I thought we fixed it. And you're like, yeah, I think we fixed the wrong thing. So That was pessimistic, but since I was the first to go, that whoever's last has to be more optimistic. So
Well,
sorry
and-
about that, but
Well,
that's
with Stacey, Stacey, get ready from so, but I hear you, and I think that's a great point. So Stacey prepares some good, some positive.
There we go.
But on a serious note, I think, and I do think that there's other ways to be as part of the solution. I think all of you have given our legislators, our policymakers, and all of it some solutions to care. And also, it's all about cost savings. I think all of what everybody's doing here and some of the work that I know Stacey's doing on a consultancy basis really is about being a part of the solution. So Silo, some final thoughts from you?
Sure. I think trying to be more positive than the approach we just took. To serve any individual with ID, ASD, we need to be more innovative and creative, and also really need to think about the person as a whole. Again, what Chris said, I'm opposing. And need to put in all the services and what they need into their environment rather than grabbing them. I think what I described the case before with a child who's needing multiple medical, we are using our thinking cap and being innovative and trying to recreate that hospital environment in a home-like setting. It requires a village and a lot of planning and need to put all the supports in place. But rather than keeping the child in an inpatient bed, I think we are making the child to have a quality of life and being a child again. I think that's the approach we have been taking, and can't do this alone. And I think every panel member already mentioned that we need partnerships and we need to plug into other organizations and providers and hospitals, maybe experts in certain areas. We need to plug into those with the expertise, and then really it takes a village to create a program like that. And I think we are definitely doing that to cut down and add up to the healthcare expenses, to cut down those expenses from the inpatient hospital to the home-like setting. It's almost like 1/3 of the cost.
Great points. Melissa?
Yeah, I think my point is probably going to be very similar to that. It's probably just this straightforward. As a system, we have to start thinking about healthcare as more than just medical and hospital-based care. Everything is slanted through that lens, and because of that, we're always running to catch up, or we're fighting, to Stacey's point. How do we save the hospital's money when by the time they get to the hospital, from my view, we've missed a lot of opportunities. So I would say just to, as a system, shift and find every opportunity to continue to change that perspective of healthcare just means medical or hospital-based care.
And last but not least, Stacey?
Yeah, I think I am optimistic, right? And that's my personality anyway. I'm a solver, but a lot of the solutions are already here. Right? We don't need to wait for technology to build something. You and I and everyone on this call can order anything we want, from a pizza to a car service to a telehealth appointment right on our phone. But the folks that we support don't always have that at the level they need it. So I'm going to call out just two of my favorite technology solutions right now where I have no skin in the game, although maybe I should because I use them so often. But if you look at Floriotech, which is virtual reality for kids with autism, just an incredible thing. I have a 21-year-old son on the spectrum. I wish that I had that for him when he was younger. Social skills, public transportation, how to navigate friend group, how to interact with the police, all kinds of things that you can do through a virtual reality headset, which is the way that kids want to learn anyway. It's already here. Awake Labs, another one that I absolutely love. Tech assessments, using technology for people with disabilities, behavior interventions, using biometrics before it gets to an explosive point. Again, my son was a desk flipper when he was younger. If he had the Awake Labs Fitbit, we would have known when that behavior was coming and could have intervened and saved thousands of hours of crisis services. So what I'm saying to you is we have to look outside our silos. We have to look outside the lane of head down operations, managing the services that we do, look across sectors, go to conferences outside of your lane, and kind of lean into other areas of our world that's using innovation right now because it's here. We're just getting the crumbs of it. And I think we have to stop settling for the crumbs and get to the entree.
Excellent points. Well, thank you, everyone. round of applause for all our speakers. We really appreciate you. And I think that Janny said, you know, that you make our families, you give us hope, and thank you from the families that are on here. And I will also thank you for everything you do, all of you here, and your strategy, vision, and just amazing leaders. So next in April, don't forget the next forum around the cliff, which is again part and solutions around how to get around that. With that, I want to thank everybody for chiming in and for listening to us, and we'll be back next month. So thank you, and again, thanks to our phenomenal speakers.